Our next speaker is Dr. Gregory Cooper. He may look a little familiar as he was this morning's moderator. Dr. Cooper is a behavioral neurologist practicing at the Norton Neuroscience Institute, where he serves as Chief of Adult Neurology and Director of the Memory Center. In addition to clinical practice, he's served as PI of numerous clinical. Welcome.
Thank you. Thank you. And again, kudos for the countdown music, although the topic that we're going to cover for this session is treatment of Alzheimer's disease and really focusing on anti-amyloid therapies. And I can tell you for that continues to be a pretty big deal. So to begin with, I don't have any disclosures. We'll start with some background, and I should preface this by saying some of the slides may get a little bit detailed, and I'd encourage everybody to stay with me at kind of a high level. My goal isn't for everyone to know really lots of details about the clinical trials for these drugs, but to have a good general comfort level and acquaintance with the overall data. So to understand these, we really want to start out with an understanding of the amyloid hypothesis. It's not the only idea in Alzheimer's disease, but for many years, really decades now, it has been the prevailing idea as to the underlying cause of Alzheimer's disease. And very simply, it states this: it's the deposition of beta amyloid or amyloid in the brain that then is the key trigger to a long and complex cascade of events, ultimately leading to what we clinically know of as Alzheimer's disease. So looking at it sort of graphically, we start with amyloid deposition. That leads to synaptic dysfunction, so problems with the connections between neurons. Then tau-mediated injury, that's where we get the neurofibrillary tangles we all learned about in school. And then atrophy and ultimately cognitive decline. Okay, so here's what that looks like if we could really look at the cells themselves. So if you look at this top panel, the long squiggly line is a protein called the amyloid precursor protein. And it's normally present in the brain, really throughout our bodies. And it certainly serves some normal functions, although all of that isn't well worked out just yet. But what's important is that when it's metabolized in a particular way by a couple of enzymes called secretases, these are the scissors down in that lower left-hand panel, it releases this golden fragment, that's beta amyloid. Now, that's happening normally all the time, no big deal. And really, for most of us, it's dissolved kind of in the fluid in and around the brain. It gets cleared from the brain through different mechanisms. And again, not a big deal. But if it doesn't get cleared properly, it starts to accumulate too much. It starts to form these plaques that you see in that far right-hand panel. And to an approximation, that's where we think the trouble really begins. So what's the evidence to support this? And I'll go over three broad areas that support this, from pathology, genetics, and from biomarker studies. So from a pathology standpoint, the pathological hallmarks of Alzheimer's disease are plaques and tangles. And the plaques are made up at their core of this protein, amyloid beta protein. Now, there are other proteins involved. There are degenerating neurites or nerve sort of processes around the edge, but at the core is amyloid, these amyloid agglomerations. So from a pathological standpoint, this certainly seems to be very important. What about genetics? Well, there are relatively uncommon or rare genetic conditions where it's autosomal dominant. If I inherit this particular mutation and live long enough, I will develop Alzheimer's disease. It's a small minority of people, but they are known. And essentially in all of these mutations, they act by increasing levels of amyloid in the brain. In Down syndrome, virtually everyone with Down syndrome, if they live into their 50s, will develop Alzheimer's disease. Down syndrome is related to trisomy, or a third copy of chromosome 21. The amyloid precursor protein is on chromosome 21. So it is at least postulated that people with Down syndrome develop Alzheimer's disease because they have an increased volume, if you will, of the amyloid precursor protein and subsequently of beta amyloid being produced. And then the main risk factor gene that we know of, the ApoE gene or apolipoprotein E, we all have different combination of alleles. We have two alleles. The E4 or epsilon 4 allele is associated with a higher risk for Alzheimer's disease, one, or if we have two copies, a much higher risk. And again, that is associated with a greater burden of A beta or beta amyloid. So all of these different genetic mechanisms, whether it's a dominant mutation, whether it's Down syndrome, a third copy of the gene, or it's through ApoE, they all seem to be associated with amyloid. Well, then a few years ago, in Iceland was discovered a mutation of the amyloid precursor protein that actually reduces the formation of A beta or beta amyloid. So we still have the amyloid precursor protein, but because of this mutation, it blocks one of the enzymes, the beta secretase, so it does not release that small fragment, the beta amyloid. It reduces it by about 40%. Well, not only is that mutation protective against Alzheimer's disease, it's even protective against the normal cognitive decline that we typically see with aging. So we have now good evidence that a mutation within the very protein or within the very gene that encodes ultimately for beta amyloid, that can have protective effects. So we've got pretty strong genetic evidence to support this. Then what about biomarker evidence? And this takes you back to a very similar slide that Dr. Hart showed. But when we study people for maybe 15 to 20 years before they even develop cognitive symptoms, we see this very orderly sequence of events. The very first thing, this red bar, is an increase in beta amyloid. And then you see an increase in tau-mediated neuronal injury. Think again of neurofibrillary tangles. And then brain structure. And then finally, at the far end, memory and clinical function. So we know that one of the very first steps that seems to reliably happen is the deposition of amyloid. So while there is still some debate about it, you can see there's a very large body of evidence that supports the central role of amyloid in Alzheimer's disease. So for that reason, there has been a lot of interest in creating anti-amyloid therapies. The logic would be, well, if amyloid is at the heart of this, if we somehow stop or block or remove amyloid, can't we then treat this disease more effectively and change the course of it? Well, we've been working on this really my entire career since probably the late 1990s. And it reached a point in 2021, the studies were a bit earlier of that, with the FDA approving a new medication called aducanumab, or the brand name was Aduhelm. They approved it for the removal of amyloid. And that is an important distinction. The clinical trials were stopped after a futility analysis said, you're never going to see any benefit from this medication. And then the company a while later said, well, we probably shouldn't have stopped the trials because when we looked at the data more carefully, we actually do think that there is clinical benefit. So they submitted to the FDA. The FDA did not confirm that there was a clinical benefit, but the FDA did say very clearly this medication removes amyloid, and we believe using that as a biomarker, it's very reasonable to expect that there will be a clinical benefit. They amended the approval in July of that same year, saying, well, it's indicated for mild cognitive impairment or mild Alzheimer's disease, after really quite a bit of uproar from the medical community. Many people did not feel this medication should have been approved, and several of the people on the FDA advisory panel who voted against approval resigned over this. It never went very well, and Biogen announced the discontinuation of sales this past January. So that was really a false start. Fortunately, something better came along after that. In January of last year, the FDA granted an accelerated approval for a new medication, lecanemab. Lecanemab is also designed to remove Alzheimer's disease. That accelerated approval was, again, based on the removal of amyloid, not based on clinical benefit. And so for the first few months, there was very little use of this medication, and it really wasn't covered by insurance. But in the meantime, the company had generated the data of clinical benefit, submitted that to the FDA, and on July 6th of last year, FDA granted full approval for lecanemab based on the study results. And we'll look over those in a minute. In a little bit of a surprise move, CMS or Medicare made a declaration of coverage essentially concomitantly. So as of July, then we had both full approval and coverage. And we were able to begin infusions here in Kentucky the next month in August. So let's talk a little bit about lecanemab. Lecanemab is a monoclonal antibody. It has high affinity to soluble amyloid beta or A beta protofibrils. And why might that be important? One school of thought states that it's the protofibrils, just as the amyloid is starting to stick together, really before you have full plaque formation, that is the toxic form of beta amyloid. And so if we can target those, we're targeting the most toxic part of amyloid. Therefore, we should see our maximal effect. Now, that part is more theoretical, but that's the idea behind it. So, based on very promising results from early phase trials, Clarity AD, a phase 3 trial, was initiated. It's an 18-month double-blind placebo-controlled parallel group trial, 1-to-1 randomization. Patients got lecanemab 10 milligrams per kilogram IV, an infusion every 2 weeks versus placebo. And looking at the data, and again, I want you to come away with this from kind of a high-level view. I'm not trying to get too lost in the weeds. But the first graph here shows what happens to amyloid. And you see in the top bar, the blue is placebo, so there's a slight increase in levels of amyloid. I would tell you at this point of the disease, people have just about reached their maximum level of amyloid already. So this is exactly what you'd expect. And then importantly, the gold bar, those treated with lecanemab, you see a fairly marked drop in lecanemab levels, really to the point that over here, if they were to get a PET scan, they might be considered amyloid negative at that stage. So clearly, the medication is effective at removing amyloid. That's true. But does it help us clinically? Well, the main outcome measure, and this is what this is showing, is something called the CDR, Clinical Dementia Rating Scale. The SB stands for sum of boxes. Look at it this way. It's a fairly global scale that's looking at trying to combine measures of cognition, measures of day-to-day functioning. It includes a semi-structured interview and exam with both the patient and the caregiver. And so that should give us a pretty good global view of how people are doing on this medication. And the blue bar are those on placebo. They decline at a fairly expected rate. And the gold bar are those on lecanemab, and you can see they begin to separate. And arguably, those bars are continuing to get wider as we go along. And in subsequent open label trials, those bars continue to widen. So based on that, we could say that lecanemab does not reverse memory loss. It doesn't stop memory loss, but it does change the course. It is disease course modifying, and it does significantly slow down the pace of this disease. Now, looking at a couple of other measures, this is an ADL score, an activities of daily living score. You see the same thing. There's an expected decline on placebo, the blue bar, and less decline on the gold bar. Arguably, this scale looked a little bit better for the medication than the CDR did. And if you look at all of the different scales that they used, the amyloid PET is less helpful here. We saw that it clearly removed amyloid. But if you look at a number of different measures they use, you can see that there was a slowing in decline ranging from as little as 23% to as much as 36%. Main outcome measure was 27%. And we often will tell patients and families that this medication, based on our current data, slows progression by approximately 30%. So that's the good side of it. What are the potential issues with it? And if you look at total AE, side effects in the trial, you have 80 to 89% of people with some type of side effect. That is not uncommon. Having almost 82% of people on placebo have some side effect is not necessarily uncommon. What you really want to do is look at the difference here. And there is a little bit higher risk of side effects with lecanemab, not surprising. Serious adverse events, a bit higher with lecanemab, but overall that looks pretty good. In terms of death, they're about equal. You can argue that you had one fewer death in the treatment arm than you did in the placebo arm. But it should be pointed out that after publishing this data, 2 additional deaths were reported in the press. One patient was on a blood thinner and developed an intracerebral hemorrhage. Another patient got TPA for stroke and developed an intracerebral hemorrhage. And because of that, experts are recommending that we avoid anticoagulants in these patients. In the trial, people were allowed to be on anticoagulants, but because of those subsequent deaths, caution has been encouraged. And then in the red box are the 2 things that I think are most important. We counsel people that about a quarter of patients, a little bit more, have an infusion reaction. Now, these tend to be things like headache, fever, chills. They tend to be pretty mild. They tend to be pretty self-limited. That has not been a major concern for us. The more concerning side effect is something called ARIA. It stands for amyloid-related imaging abnormality. And what I tell patients essentially is it means swelling or bleeding in the brain, which does sound potentially scary. About 1 in 5 patients, or a little more, 21.3% of patients on this medication would be expected to have some degree of ARIA, swelling or bleeding in the brain. Now, I'll show you some data in a minute that shows most of those are asymptomatic. They don't cause any symptoms, but it's still important to know that. I also think it's worthwhile pointing out that a little over 9% on placebo had ARIA. This is a condition that arguably is related to amyloid and can happen in the absence of a treatment like lecanemab, but there's no question it's more likely in someone with lecanemab. Now, here's what that looks like on an MRI scan. So I'll show you first panel B up here where the arrows are. That's ARIA-E. E stands for edema. There's a little bit of swelling there. So you can see the little bright white signal on, I think, a FLAIR image, maybe some sulcal effacement. So you just see a little bit of swelling there. Or ARIA-H. H stands for hemorrhage. And in the circle over here, you can see the little dots look like little grains of pepper. And those are microhemorrhages. In real life, we wouldn't be able to see them, but because of a blooming artifact for this type of MRI image, it blows them up large enough so that we can see them. And typically, that's what we're going to see, microhemorrhages. You can have what's called superficial siderosis, some bleeding along the surface of the brain. And there is a 0.7% risk, I believe, of a macrohemorrhage, a larger bleed in the brain. Less than 1%, but certainly something we still worry about. So, looking back at the trial, if we think about ARIA-E, edema, swelling, the risk of just that was about 12.5%, typically mild to moderate based on radiologic criteria, MRI, asymptomatic, no symptoms in 78%, predominantly occurring in the first 3 to 4 months, mostly resolved within 4 months. Symptomatic overall in about 2.8%, or I will tell people 3%. There's about a 3% risk overall of having symptoms related to ARIA. And those symptoms are typically things like headache, nausea, confusion, maybe vision changes. ARIA-H, the hemorrhage, is going to typically go hand in hand with ARIA-E. And here's that number again, 0.7%. There were 5 people out of almost 900 that developed a larger hemorrhage. So I guess I already went over this, but symptoms you might expect: headache, confusion, visual changes, dizziness, nausea, gait impairment. In serious cases, and we expect this to be less than 1%, but in very serious cases, we might see seizures, status epilepticus, more of a general encephalopathy, stupor, or even focal deficits that will mimic a stroke. So that's a rough overview of the good and the bad. With this medication came, independent from the FDA or the company, published appropriate use recommendations. And we tend to follow these pretty carefully. And I think this is good to keep in mind. So what are the inclusion criteria? Mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease. Really, I think a good, useful way to look at that is a mini-mental state score of 22 or above with the presence of amyloid. So we have to do a biomarker study, as you heard earlier, typically spinal fluid or PET. And then they gave age criteria of 50 to 90. That's largely based on how the clinical trial was doing. So again, inclusion criteria, the main thing we're looking for is relatively mild impairment, mini-mental state score 22 or above, and evidence of amyloid by biomarkers. Those are the main messages. So what about exclusion? Well, inability to have an MRI. We have to have an MRI. One of the reasons we're doing that is to rule out significant vascular disease. Now, CAA stands for cerebral amyloid angiopathy, and that's, you don't have to worry about that too much. What we're really looking for before treatment, if there are more than 4 microhemorrhages already in the brain, not uncommon to have a couple, but if there are more than 4, that would be an indication we may have this vascular disease called amyloid angiopathy. Or if there's a single large hemorrhage greater than 10 millimeters or superficial siderosis. All of those things tell us that this individual, first of all, may have a different disease causing their memory loss, but also that they may be at a heightened risk of developing bleeding complications, ARIA-H. So we want to be very careful about that. Other things, multiple lacunar strokes, a stroke involving a major vascular territory, or severe subcortical hyperintensities, those non-specific white matter diseases we always see. If those are all very severe, again, pointing really to a potential alternative etiology, vascular disease rather than Alzheimer's disease, but also help us kind of exclude people that may be at a higher risk for complications. Other things, so current anticoagulant use, warfarin, Eliquis, Xarelto, those were not excluded in the trial, but because of our concern about bleeding risk, we exclude those now. Stroke or TIA within the past 12 months, other immunologic disease, uncontrolled bleeding. History of seizures, that one is somewhat debatable. The appropriate use guidelines said any history of seizures, period. In the clinical trial, the criteria was any seizure within the past 12 months. And I think that is one of the criteria that we may be more likely to give a little bit than any unstable medical condition. How's it used? It's an infusion, and patients need to know it's an infusion every 2 weeks. Infusion itself takes about an hour. With the first infusion, we observe people for about 3 hours. With the second one, 2 hours. And then after that, about 30 minutes. But people need to understand, especially those first couple, they're there for a significant period of time. And it is a significant commitment to undergo treatment with this drug. And then monitoring. So we mentioned that ARIA is our biggest concern. Most of the time it's asymptomatic, but we still want to recognize it. So we do MRI scans before the 5th, 7th, and 14th infusions, possibly after a year. And we're looking very carefully for asymptomatic ARIA. If they have evidence of ARIA and no symptoms, depending on the severity on the MRI, we may or may not continue. But at that point, we're going to start doing MRIs every month, again, to just follow this very, very carefully. So these are essentially quotes from the recommended use criteria. ARIA, most cases are asymptomatic. Few cases are serious. Very rarely fatal. In the main trial, about 21% had ARIA, a little less than 3% were symptomatic. And then that can vary based on their ApoE testing. So we do highly recommend genetic testing, and that can give us a more accurate idea. If someone has 2 copies of the E4 allele, for example, their risk of symptomatic ARIA symptoms is now not 3%, it's 9.2%. If they have 1 copy, it's 1.7. If they have no copies, it's 1.4%. So that helps us stratify. And we've even had patients that when they get that result back, they may make the decision not to pursue this treatment because the risks are higher than initially anticipated. And I would say our experience has been fairly well in line, I believe, with the expectations from the trial. If someone has ARIA, if it's mild and asymptomatic, we keep dosing, we follow it. If it's moderate or severe, we'll stop treatment, or if there are symptoms, we'll stop treatment. We'll monitor monthly MRIs, and then we can consider resuming treatment once the symptoms in the MRI stabilize or resolve. If someone has very severe ARIA, they go straight to the hospital. We, of course, would stop dosing. And typically they're going to be, if we confirm that it's ARIA, we've excluded some other etiology like ischemic stroke, we're going to admit to the ICU, treat them with steroids, and monitor carefully. Now, I alluded to this, but it's worth bringing up again. In one of our big meetings at Clinical Trials in Alzheimer's Disease, or CTAD, last fall in October, the company that makes lecanemab presented some additional data showing that a subcutaneous form of this medication was at least equally, if not slightly more efficacious. And they've already submitted their FDA application for that. So that will be very helpful for patients, I believe. And then they showed in open label extension studies that separation between treated and untreated continues to widen, suggesting that we really are altering the course of this disease. It's disease course modifying, and that benefit, notwithstanding that the disease is still marching on, that benefit continues to accumulate. Okay, so this is just telling me it's time to pivot and talk a little bit about lecanemab. I'm sorry, not lecanemab, donanemab. So donanemab is another monoclonal antibody aimed at amyloid. So in that way, similar to lecanemab. It's currently under FDA review. Earlier this month, an FDA advisory panel voted unanimously in favor of approval. And frankly, I think we all expected this to be approved at the beginning of the year. So I think it's only a matter of time. But it's worth knowing a little bit about this medication. And I'll go through this last part a little bit quickly. Again, let's not get too hung up on the details of each slide. So the results of this were announced both at a conference and in print simultaneously, published in JAMA, the Trailblazer ALTS 2 randomized clinical trial. And it was a little bit, I think, an interestingly designed trial, which may be what's giving the FDA a little bit of trouble. So they enrolled people between the age of 60 and 85, a mini-mental state score of 20 to 28, so slightly lower than donanemab. Instead of 22 as a cutoff, they went to 20, but pretty comparable. Similar exclusion criteria in terms of MRI findings, but they required that Alzheimer's disease pathology be confirmed both by an amyloid PET scan and a tau PET scan. So the presence of amyloid is not enough. They said we have to have amyloid and tau. And this is sort of a graphic looking at that. So if they had no or very low tau, they were not enrolled. So positive amyloid, no tau, by their criteria, that doesn't work. What they were really focused on was low or medium tau, but they enrolled people with high tau. So as we look through the data, you'll see where we combine everybody with tau, or we'll combine people with low to medium tau versus high tau. And I think you can think of that as people who are very early on the disease course and later on the disease course. And are we more effective if we can catch people at that very early time point? I regret putting this slide in here, but it brings up an important point. In this study, so another wrinkle was people were randomized to treatment or placebo. There was a titration, but they did repeated PET scans. And at the point that the patient becomes amyloid negative, then they were converted to placebo. So you see at this top bar, people are started on treatment, but then throughout treatment, people are dropping out of treatment to placebo because now they are amyloid negative. The logic is we've removed all the amyloid, there's nothing left to do. Now let's just see how they do clinically. So that was the logic. And they had a number of outcome measures. The main measure that we'll be looking at is something called the iADRS. And it's a little bit similar to the CDR, perhaps, in that they're trying to come up with a composite score looking at tests of cognition, looking at tests of activities of daily living, trying to get a single number that represents overall function. So when we look at that, when we look at their primary outcome measure, the iADRS, on the left is that low to medium tau group. So the idea is these are our early people. They slowed progression down by 35%. It's a pretty good number. If you combine it, low, medium, high tau, then it's still a clear separation, clearly statistically significant, but not as impressive, 22%. Now, if we look at the CDR, this was not their primary outcome measure, but I bring it up because it was the primary outcome measure used in the lecanemab trials. Again, look at that low to medium tau population, slowed progression by 36%. That is significantly better than we saw in lecanemab, 27%. If we look at all tau, low, medium, plus high, slowed it down by 29%. Still significant, still good, much more in line with what we saw with the lecanemab study. And then this is showing us, if we look at people that were dropped off of treatment into the placebo arm during trial, they continue to do better. The gap between placebo and treated at one point continues to widen. So may not have articulated it well, but the point they're making there is it doesn't matter that we stop their treatment. The people that were at least initially on treatment are continuing to benefit and continuing to separate from people that were never on treatment. That confirms the idea that they don't need to be on treatment the entire time. That's the logic. Now, this is, I don't want to go too far with this, but this is very exciting to me. So they had a pre-specified subpopulation. This is not the main outcome measure they were looking for, but let's just take people with mild cognitive impairment. So clinically mild. We're taking the mildest group clinically. And out of those, we're taking people with low to medium tau. So the logic is clinically the most mild and pathologically the most mild. We're getting these people at the earliest possible point. What do we see? On the main outcome measure, slowed it down by 60%. That's sort of mind-blowing for somebody like me. And on the CDR, maybe not as good, but 46% slowing. So if you just take that little population, and again, that's we need to confirm this in subsequent studies, but it potentially is very exciting. If we catch people very early on the disease process, we're starting to see a bigger and bigger impact of treatment. What about ARIA with this? And just look at this panel with all the little people there. What they are showing us is 24% of people, all of those people, pink and black, I guess, had ARIA-E. That's about twice what we saw with lecanemab. 6 of those were symptomatic. So again, about twice what we saw with lecanemab. So if we summarize the data from donanemab, treatment can be stopped when amyloid negative. That's new. Efficacy, it does seem clear that the progression of the disease is slowed and that benefit continues to accrue even after stopping treatment. And potentially, and I really would highlight potentially, the benefit's very high when started early. Now, the counter to that is the risk of ARIA. The risk was almost 37% of all treated patients. Now, that's combining ARIA-E and ARIA-H. And 6.1% had symptomatic ARIA. So that's about double what we saw with lecanemab. So higher risk. It's difficult to compare these two directly. And once it's approved, we're going to have to be able to talk through this with patients. If you look at the one outcome measure that they had in common and really tried the best you could to compare apples to apples, one shows 27% slowing, one shows 29% slowing. I'm hard pressed to say that's a difference. So clinically, it's difficult, I think, to say there's a clear difference between the two. In terms of ARIA, there is a pretty clear difference. If you look at any ARIA, 21% to 36%, symptomatic ARIA, about 3% to about 6%. So there is, I think we can say, a roughly doubling of risk of symptomatic ARIA with donanemab. If you look at that by ApoE status, you're going to see similar things. So if we look at risk, if you're not a carrier of ApoE, 5 to 15%, heterozygous 10 to 22, 32 to 40%. So roughly shows us the same thing. I was not able to pull data out of their original article of symptomatic ARIA. And then if we look at the infusions, lecanemab's every 2 weeks, donanemab's every 4 weeks. That's advantage to donanemab. Duration, the honest answer is with lecanemab, we don't quite know right now. With donanemab, it may be limited to 12 to 24 months. So, summary, anti-amyloid agents have arrived. They do slow progression, particularly when started early. Right now, intravenous infusion is required, but subcutaneous forms are on the way. And ARIA is the thing that we are most worried about. And I have gone over my time limit. Apologies for that.
All right, no, that was great. I wanted to ask a couple of questions. I was wondering if you could speak a bit more on the general response from our patients on their kind of desire and motivation to pursue anti-amyloid therapy, and kind of speak to maybe like the cost of these treatments for patients. Sorry, a two-parter.
So yeah, so those were really good questions. It is actually a bit interesting. I would say when we started, we had tremendous enthusiasm, but that was probably a selection bias. We started, and those who were most interested found their way to us quickest. And I think we're reaching more of a steady state where for those who are eligible, I think there is a pretty high level of enthusiasm and interest. I can't say it's universal. Certainly reasonable people can look at this and choose not to get that medication. So I think it goes both ways to some degree, but I think overall the enthusiasm has been high, and certainly we've had, I think, a lot of enthusiasm among those who are receiving the medication. The cost is not trivial. The medication itself, if you were paying out of pocket, is $26,000 a year. That does not include infusion fees. That does not include MRI. So it's significant. We have generally won when we fight with insurance, but insurance can be difficult. The company has been very good about patient assistance for us. So we have generally found a way to get it paid, but that should not be trivialized, and people should understand that up front. I think the biggest part of this is just the overall burden of coming for frequent infusions, coming for frequent MRIs. This is not necessarily for the faint-hearted. People really do need to be committed to do this. So
Absolutely.
that's long-winded, I know.
No, you're absolutely. So I have a question that came in. If a patient comes to primary care office complaining of a new onset headache, nausea and dizziness, and they're on the lecanemab, what test or treatment do you recommend?
Well, so with apologies before the answer, if I see those constellation of symptoms, I'm saying go to the ER, do not pass go, and get an MRI scan. I think in our experience, most of the time the MRI has been fine, but those, particularly when you're throwing in the nausea and some of these other symptoms, the risk of serious ARIA is just too high. So you have to have that checked out.
Sure. I have another question. What's your clinical assessment after 6 months of treatment?
Well, it's really the same assessment we would do in clinic anyway. And I guess in my mind, this is maybe a little overly simplistic. I break it down in two ways. First, the interval history. What does the patient and frankly, more importantly, their family say? And then second, I'll do some standardized measure, MMSE, MoCA, something like that. But I think the real question is how do you assess the efficacy of this medication? And that's tough because the truth is you're assessing it based on faith. A significant number of people on placebo won't change significantly at 6 months. You're always happy when they don't change at 6 months. Is it because of the drug or not because of the drug? So judging it is extremely difficult. So you still measure those things, and you have in your head the idea of what is an anticipated progression. But I'm sorry to say I don't have a direct marker to say it's helping clinically. At some point, we probably will be measuring amyloid, and we can at least say we're removing amyloid.
For sure. The last question, these treatments seem to be most effective when started very early. Theoretically, the pre-symptomatic patients would stand to gain the most, but are not currently recommended for treatment. What do you think is the future for identifying such patients?
So I love that question. So first of all, right now, I will say those patients should not be treated. And there's debate about this, but I am in the camp that would say if there are no symptoms and they have biomarkers, I don't actually know if they're going to ever have problems. So I don't want to expose them to risk. However, there are ongoing studies trying to address this question. And my personal optimistic belief is that we will eventually find that we do want to find those evidence of those biomarkers early on, and we will find out that if we treat them with anti-amyloid agents, we prevent the onset of dementia. Understanding, so maybe my risk is 40%, and I start that and it cuts it down to 5%, and I accept the risk of ARIA that goes along with that. So I think we do get to that point. We are not there now. I think in the next 4 or 5 years, studies will probably tell us if that's what we ought to do.
Well, thank you so much. That was incredibly informative.
Well, thank you all.